this 8:30 meeting on Tuesday. We do have 3 bills that we will be hearing today. We're going to take a maximum of 15 minutes per bill. So we have 3 verbal, we have 2 proponents and 1 neutral on our first bill. If you could please keep your time, we'll be timing you between 2.5 and 3 minutes so that we have plenty of time for questions. Ask that you not duplicate each other if you can, so that we can use our time very concisely. For some of you who don't know, this is the result of turnaround, where House bills come over and we received, I think, a total of 14. And we have about 2 weeks for us to be hearing these bills and working these bills. So final action is a different day than hearing the bills. We'll try to get through as many as we possibly can. My personal opinion is, if on the House side, the majority leader felt it was important enough to place it within a committee, and the chair of that committee felt it was important enough to have a hearing, and the committee, then they took final action, and the committee decided this was important enough to pass it out of that committee. Then it went to the House floor, and it was important enough to pass the House floor. It's important for me to hear this bill and try to work it for them on the Senate side. So we're going to try to work and hear and work as many bills as we can. So we'll get started right away by opening the hearing on House Bill 2784 with a revisor overview.
Thank you, Madam Chair. Jenna Moyer, Revisor of Statutes Office. House Bill 2784 would transfer authority for certification of continuing care retirement communities from the Insurance Department to the Department to KDADS, excuse me. Section 1 amends KSA 39923, which is the definition section for adult care home statutes, and they add a definition of continuing care retirement community as any place or facility that combines a range of housing and services to encompass the continuum of aging care needs provided at an independent care facility, an assisted living facility, a residential health care facility, or a skilled nursing facility within a single place or facility to avoid the need for residents to relocate to a separate place or facility. Section 2 amends KSA 39936 by updating reference to a defined term in Section 1. And Section 3 amends KSA 402231. It adds a definition of continuing care and Secretary and Act, clarifying references to Sections 4 through 7. Sections 4 through 7 change references from the Commissioner of Insurance to the Secretary for Aging and Disability Services, and requires that annual disclosure statements, continuing care contracts, and audits are filed by April 1st of each year. In Section 7, a provision was added in the House committee amendments that would allow a provider to appeal a decision to not issue or renew a certification. And the other House committee amendments was striking Section 8 of the bill, and this would have lowered the nursing facility provider assessment rate for continuing care retirement communities, and that was stricken in the committee. And this would take effect on July 1st, 2024, and it passed the House on a vote of 118 to, I had 0, but Eileen had 1. So it's either 118 to 0 or 1. Oh, and I'll be happy to answer any questions.
Questions, any questions, any committee? That's not going to work. Committee, any questions for Jenna? No way. Thank you, Jenna. And we'll begin with our first proponent, which is Lacey Hunter.
Good morning, Madam Chair, members of the committee. Thank you for this opportunity to provide testimony on House Bill 2784, which makes several changes to current statute regarding continuing care retirement communities, or CCRCs. CCRC is a nationally designation for a facility type with multiple levels of care, ranging from independent living to skilled nursing. Oftentimes, residents are charged an upfront fee before admission or agree to a fixed price payment plan were intended to cover the range of care needed for the duration of their life within the services provided by the CCRC. House Bill 2784 makes several policy changes related to CCRCs. It further defines what a CCRC is, and it moves registration of CCRCs from the Kansas Insurance Department to the Kansas Department for Aging and Disability Services. KDAD supports adding the definition of a CCRC to the definition of types of facilities that KDAD's licenses on page 3, number 9 of House Bill 2784. The House Health and Human Services Committee amended this definition to connect the facility types with an or instead of an and, which provides more realistic expectations of levels of care that can be provided by a CCRC. House Bill 2784 also transfers the authority of certification of CCRC facilities from the Kansas Insurance Department to KDAD's. KDAD's is neutral on this change and leaves that policy decision up to the legislature. With amendments made by the House Health and Human Services Committee, KDAD's is comfortable with this bill if it were passed in its current form. Those amendments included removing CCRC from the definition of an adult care home. This change would have created a licensure category for independent living facilities that currently does not exist, and striking Section 9, which adjusted the rates of the quality care assessment. KDAD's had concerns. The rates originally included in the bill would not comply with federal requirements, but put the entire quality care assessment program at risk. Thank you for this opportunity to testify on House Bill 2784, and I'm happy to stand for questions at the appropriate time.
Thank you, Lacey. We'll wait until the rest of the proponents, and that would be Eric Turek.
Good morning, Madam Chair, members of the committee. Eric Turek from the Kansas Department of Insurance. We stand here today in support of House Bill 2784, but I would like to express our exclusive support for just the components of the bill that detail the transfer of authority from the Insurance Department to the Department for Aging and Disability Services. The other aspects of the bill we have no position on. I would like to note that currently CCRCs, in terms of their regulation, the only aspect of regulation that touches the Insurance Department is the registration for these facilities. Every other aspect is housed within the Department for Aging and Disability Services. On our side, we require an independent audit, financial statements, a sample contract between the user of the facility and the facility itself, and basic business information. And the Kansas Department of Insurance, we are in the business of regulating insurance and securities. That's what we do best. And as I stated, KDAD's is already regulating these entities by every measure. We feel that KDAD's is a more appropriate agency to house this authority. Be happy to stand for questions.
Committee, that concludes the proponent testimony. Do we have questions for either of the? Yes, Senator Holscher.
Yes, come back, Eric. Thank you. I was looking ahead to the neutral testimony from Leading Age, and I was curious about the 2 points that are brought up as far as adding Home Plus to the list of care settings, and then that April 1st date in terms of the reporting period. What are your thoughts in that regard?
Sure. As I stated, we are exclusively in favor of just the transfer piece. The other components, we don't have a position on. So I'll say that those don't necessarily pertain to the Insurance Department, so I won't necessarily comment on those. Yeah.
Other questions, committee? Senator Erickson.
Thank you, Madam Chair. I'm just wondering if someone could address the fiscal note I'm looking at. And Eric, maybe I can roundabout get to this, because according to the fiscal note, KDAD's would have to add 6 new positions. And I'm wondering, would there be a corresponding reduction in FTE for whoever is handling this licensing and registration at the Insurance Department? I mean, I'm wondering about that and the increase in fees on the facilities. Thank you.
Sure. So I'll speak to just the FTEs at the department. In terms of the number of FTEs that deal with the registrations, I'm not entirely sure that we have. Well, no, I am confident we do not have one sole employee devoted 40 hours a week to the registration. I don't think it. What we do at the department concerning just the registration is not a full-time FTE, perhaps half, perhaps. I couldn't necessarily quantify that right now for you. In terms of the additional FTEs for the other agency, I'll let them comment on that.
Lacey, do you want to come up and comment?
Sorry, having to create a survey kind of category and individuals who can survey and oversee the licensure of independent living. With that being removed from the bill, I believe we went down to 1 FTE.
Could you get information on that for this committee of an amended fiscal note? Great, thank you. Committee, other questions? I have a question. If you could stay up. Thank you. You mentioned the fixed price payment plan. Could you explain to us what that is?
The quality care assessment? I'm not sure. No.
I just wrote down your words when you were talking about the fixed price payment plan. So it brings the question, why was this group under the insurance department in the first place?
I am not sure why the original assignment of certification for CCRC was with the insurance department. I don't know the history on that one. I apologize.
So in doing just a little bit of research, it appears that there was some writing of what we would consider today to be long-term care insurance. That's perhaps the payment plan that you were talking about. It's not just this is how much you owe, it's that you could pay up front, you can get basically like long-term care plan or long-term care insurance, which would make sense why it was initially under the insurance department.
Sure. I apologize. Yes, and I can address the fixed payment plan now. So a lot of times when individuals are looking at or decide to move into a continuing care retirement facility, their level of care needs tend to be more on the independent side, but they are looking and seeking at communities that have this designation because the designation goes through skilled nursing care, often end-of-life care. And so these communities, when they're working with individuals to come live there, often have them either sign an upfront fee and or some sort of fixed payment plan that would then allow them to stay in the community through the different levels of care as they age through life. So whether they stay in independent living and there's a sudden death, or they go from independent living to assisted living to skilled nursing needs and then pass. But that fixed payment plan and or the upfront fee would be part of the contract between the individual wanting to live within the community and the community itself.
Would it be possible for me to see a copy of that, of the contract that's being used?
I can reach out to, I have a couple of contacts in the local continuing care retirement community. So I'll
Great.
see if Carol can get me one from Aldersgate.
Thank you. And Eric, could you come back up, please? So we talked about this just briefly, and I understand that the registration, et cetera, and certification, that seemed more appropriate, the insurance department, because I think this was initially facilitated by KDADS, or was it by the insurance department?
In terms of the registration,
Right.
yeah, it's my understanding it was originally housed, it has been housed within, just the registration aspect has been housed within the Department of Insurance. And I think that this predates a lot of regulation that has occurred over the years when it comes to adult care homes, nursing facilities, and things like that.
And so what was the impetus for this bill? Did it come from KDADS, or did it come from the insurance department?
At the department, we do strive to ensure that our operations are narrowly tailored to what we do best. And this is part of that effort. We have been engaged with talks with KDAD since last year. It really seems that KDADS is the more appropriate agency to regulate CCRC's by every measure, not just every measure minus the registration.
Thank you. Committee, additional questions on this? Seeing none, we'll move to our neutral proponent, which is Rachel Monger.
There we go. Good morning, Rachel Monger with Leading Age Kansas, and so happy to be here. We are testifying as neutral on the bill today. On the House side, we were an opponent, so we are making progress as far from our perspective on this. And I just want to be clear about where we stand on different issues in the bill, because now, as you know, there are a couple of them there. So we're neutral on the issue of whether to move oversight of CCRCs from KID to KDADS. As the association who generally has represented CCRCs for many, many decades now, we do support tightening up the definition of CCRC in our statutes to ensure the integrity of the certification, because it is written very, very broadly presently. And we do think it'll have an added benefit downstream to ensuring the integrity of our bed tax program, which now has been removed from the bill, so that's a very good thing. So ours, neutral testimony on the bill, as you can see, it's in front of you, is we do have a couple of suggestions. The bill was written without a lot of input from the actual providers that it applies to, so we've really struggled with how it's being defined in the bill and how that's going. So we do have a request that the bill be further amended to add Home Plus to the definition of CCRC in section, first part of the bill. And the reason why is because they added all the different definitions of like residential adult care home settings, but they left out Home Plus, and today, to us, that seems like an oversight rather than an actual policy decision. And then the second thing is the April 1st deadline. Not all of our providers have a calendar fiscal year, and so to us, that's why the original statute was always written to say you turn in your disclosures and all of those things a certain amount of days after the end of your fiscal year, rather than setting that certain date of April 1st. And so we are concerned that if we don't preserve that original language, it may require some burdensome changes that we don't think would be necessary to operation of the program.
Committee, any questions for Rachel? Yes, Senator Petty.
Thank you, Madam Chair. And Rachel, thanks for being here. So,
Where are you?
sorry, dear. We'll play this one. So on, excuse me, I understand about adding the Home Plus to the definition, but on the date to comply, would it work if there was a phase-in to move to that date?
I think that we have organizations that have had their fiscal year for a very, very long time and have a lot of things built around it. So requiring them to change that fiscal year without a really compelling policy reason, we would prefer not to have them do that.
Thank you.
Additional questions for Rachel? Seeing none, thank you, Rachel, and thank you to all of our conferees. And this closes the hearing on HB 2784, and we will open the hearing on 2547 with a brief.
Thank you, Madam Chair. House Bill 2547 would authorize schools to maintain emergency medical kits and to administer albuterol or epinephrine to students in emergency situations. I'm going to start with Section 3, and I promise it'll make sense. Section 3 amends KSA 726283. It strikes the current law and replaces it with new language. Subsection A defines terms used in this section, and Sections 1 and defines terms used in this section as well as sections 1 and 2 of the bill. Subsection B1 authorizes a school to maintain a stock supply of epinephrine or albuterol by obtaining a prescription in the name of the school. The physician or mid-level practitioner who would prescribe this medication would be required to review the school's emergency medication policies established in subsection C before authorizing that prescription. Paragraphs 2 and 3 specify what the stock supply of these medications may consist of and authorizes a school nurse and and designated school personnel to administer such medication at school if the school nurse or designated school personnel reasonably believes an individual is exhibiting signs of respiratory distress. Subsection C of Section 3 requires a school to maintain a stock supply, or requires a school that maintains a stock supply of emergency medication to establish policies relating to their storage, inventory, administration, and training requirements for school personnel. Section 1 amends KSA 65-1680 to authorize a pharmacist to distribute a stock supply, epinephrine, auto injectors, and albuterol pursuant to a prescription as authorized in Section 1. Section 2 amends KSA 65-2872B, and that statute specifies persons not engaged in the practice of healing arts, and it adds to this list persons who administer albuterol to an individual in respiratory distress, and it also expands the civil liability protections by allowing emergency medication to be given not just to students or school staff, but any individual at school, on school property, or at a school-sponsored event. So you can think a basketball game if someone appears to be having a respiratory distress or one of these emergency allergic reactions. Subsection C specifies that a mid-level practitioner or a physician is not liable for civil damages resulting from the administration of emergency medication pursuant to Sections 2 and 3. This would take effect from and after July 1st, 2024, publication of the statute book, and there were no House Committee amendments. It passed the House 116-4. Excuse me. I'll be happy to answer any questions.
Any questions for Jenna Committee? Senator Steffen.
Thank you. Now, again, in the bill, you have the physicians and pharmacists and such supplying the medications, and you're giving them civil liability protection. Now, who's going to be administering the medications and who has civil liability protection?
It would be either a school nurse or a designated school personnel who has received the adequate training required by the school.
Quick follow-up. Do we have any other situation in a public setting where we have non-medical personnel civilly protected?
Yes, that would be, I believe it's KSA 65-2891, I think it's A, and that would be the emergency. So there's a 65-2891, which is emergency care by physicians, and then there's A, which sometimes we call it a Good Samaritan law, to where you would receive civil liability if you were trying to, let's say, do CPR on someone that you found as a non-medical personnel.
One more quicker, but not administer medications. Is there one where they're actually administering medications?
I mean, there is the current exception or current liability protections already for, but I guess that's school nurses. So I would have to get back to you on that. I'm not sure there's any for, at least for prescription medications that I'm aware of.
Committee, other questions for Jenna? Yes, Senator Alley.
Thank you, Madam Chair. In the first part of the bill, it definitely explains the medication and what that medication is. It defines it. I'm not going to try to say that word, but it definitely, it's an auto injector. It tells what that is. But when we go down a little farther into the second one, which would be on line 3, it says emergency medication. Is there a difference between those two?
Okay, so I'm going to make sure I'm on the right page. On page 3. Oh, okay, page 2.
Line 3, or identified as 3, it said the emergency medication is administered at school. that could include several things, could it not?
So if you look to Section 3 of the bill, it has a definition of emergency medication. This would be page 3, line 20. It means epinephrine or albuterol. And if you look to subsection A, it says, as used in this section, KSA 65, 1680, and 652872B. So the definitions in Section 3 are applied to Section 1. So it means that albuterol or epinephrine.
Thank you very much for the explanation.
Senator Erickson.
Thank you. Just real quickly, Jenna, did I hear you say that the training requirement for an individual to be able to do this is training standards set by the school?
Let's see, the definition of designated school personnel would be an employee, officer, agent, or volunteer of school who has completed training documented by the school nurse, the physician or mid-level practitioner to administer emergency medication on a voluntary basis outside the scope of employment.
What training? Who sets the standard for that training?
I believe it is the school, but I will double check and get back to you.
Thank you. Thank you, Madam Chair.
Oh, wait, I think I found it.
Okay.
It would be page 4, C4, which is line 38. This would be that the school has to have policies relating to training requirements for designated school personnel, which shall be conducted on not less than an annual basis, and the training shall include but not be limited to, and it has a list of 6 things, which include recognition of the symptoms of anaphylaxis and respiratory distress, administration of emergency medication, calling for emergency medical responders, monitoring the condition of an individual after administration of the medication, notification of the parent, guardian, next of kin, and safe disposal of the equipment. And the school would also be required to publish the policies and procedures related to the medication and the training. Is that it?
Committee, other questions? We'll move on to the conferees. Thank you, Jenna. And we'll start with Alexandra. And Alexandra, I always say your last name incorrectly because I know it's a little bit different than Senator Blasey. Am I right?
Yes, Madam Chair, thank you so much. I'm Alexandra Blasey. I'm the Executive Director of the Kansas State Board of Pharmacy. We'll just agree to disagree on how to pronounce the name. Thank you so much for allowing me to testify this morning. I actually, just because I'm one of those people, but you know, visuals are helpful sometimes. So epinephrine, albuterol. The Board of Pharmacy is before you today not because this is a bill we initiated, but because it's one that we've encouraged for several years, and you may have seen previous iterations of. We are supporters of moving this bill forward because originally, when the legislation was drafted, the Board of Pharmacy was tasked with the responsibility of adopting rules and regulations to help bring this into fruition and actually make it plausible in schools. And that was just limited to epinephrine at that time. It was not extended to albuterol. But unfortunately, what we discovered in the process of trying to adopt those regulations was, which actually were very similar in content to what you have before you, was that the Attorney General's office indicated that we did not have the appropriate requisite authority to do that. And so we went back to the school nurses and we've worked with them over the last few years to bring this together and put together some, what we believe from the Board of Pharmacy's perspective is safe language. The bill does some really key things that were not previously provided under the statute. It obviously expands to include albuterol because sometimes a student that or any other individual that's at that event that's in need may not need to go to these lengths of needing the epinephrine at that time, and a rescue inhaler or a form of another form of albuterol might be what they need to get them through that respiratory distress and not necessarily go as far as an epinephrine. In addition, the bill allows for administration to any individual at the school or school-sponsored event, not just students. It changes the role of the pharmacist to align with current industry standards and practices by allowing the pharmacist to distribute the medication and equipment pursuant to a valid prescription in the name of the school, which was a issue before. It defines terms that are necessary, and then finally includes a liability waiver for pharmacists. One of the pain points has been that unfortunately pharmacists were not willing to participate because while the prescribers were provided a liability waiver in the original legislation, pharmacists were not. And so we have not had many pharmacists be willing to participate in providing these medications to schools, which obviously limits their ability to administer them to necessary individuals. So with that, Madam Chair, I'm happy to stand for questions.
Thank you very much. We'll go to our next conferee, Kimberly Martin.
Thank you so much. Madam Chair and members of the committee, thank you for the opportunity to provide testimony in support of HB 2547. I'm Kimberly Martin, Legislative Chair for the Kansas School Nurse Organization. And this is our third legislative session working to pass the language in HB 2547. This version has moved the farthest in the process since we first started working on this issue in 2020, back when Senator Erickson was serving on House Education Committee that first heard a version of this bill. We hope 2024 is the year to get this important legislation across the finish line. Kansas school nurses are on the front line of healthcare in the school setting and must be equipped with supplies to attend the most common life-threatening situations. Emergency devices such as automated external defibrillators and emergency medications such as Narcan are becoming increasingly common in schools as they are life-saving and help to fill in the gap from the time an emergency health event is recognized, emergency help is summoned, and emergency help arrives. Stock epinephrine and stock albuterol may be used for both individuals with a known diagnosis whose medication is not readily available, and for individuals with no previous diagnosis, but who are displaying the signs and symptoms of a severe allergic reaction or respiratory distress. Seconds count during anaphylaxis and breathing emergencies. Access to evidence-based life-saving equipment and medications are necessary for Kansas schools. Among these are stock epinephrine and albuterol. Kansas needs a revised stock epinephrine statute with the addition of stock albuterol. HB 2547 fixes issues with the current epinephrine law by modifying language to include the word stock, adding albuterol to stock medications allowed in schools, bringing the role of the pharmacist in alignment with other states and adding liability exclusion language for pharmacists, expanding liability exclusion for schools, expanding the persons who may receive the medication to be any individual, not just students and staff, as long as the stock medication is administered at school, on school property, or at a school-sponsored event, and requiring schools who desire to stock epinephrine and/or albuterol to establish related school policies and procedures. Thank you for the opportunity to speak in support of HB 2547 on behalf of the hundreds of school nurses across our state. I'll stand for questions at the appropriate time.
Thank you, Kimberly. Now we'll move to Leah Flitter, or is it, did I say that right?
Good morning, Madam Chair. Leah Flighter.
Flighter.
Lazy,
Sorry,
blasey, Flighter. Filter, leaf filter, that's not my side gig. Many people have asked me about that. In interest of time, we do appear today in support of the bill. As previous conferees have noted, we have worked together for the past 3 sessions to try to get this across the line, and we're getting much closer. In interest of time, I'll just draw you to the final 2 paragraphs of our testimony. We mentioned that many of our students who have asthma or life-threatening allergies already have a prescription for medication, and that is, assessed, and the school nurse is aware of that. This helps us have some stock on hand in case, as we noted, there's somebody at a basketball game or a choir concert, someone in the stands or the audience might have an attack or a life-threatening event, and this would allow us to keep those medications on hand to allow the school nurse or properly trained individuals to administer that life-saving medication. Additionally, we appreciate that the bill provides civil liability protection to the pharmacist because that was a sticking point previously, and so we appreciate that this bill smooths the way for that. And also, we appreciate that the bill allows schools to accept donations of the medications or the funds to purchase them. So with that said, I can stand for questions at the appropriate time.
Thank you, Leah. Committee, I would draw your attention to other written testimony, but at this point, do we have any questions for our verbal conferees? Senator Erickson.
Thank you, Madam Chair, and this is for everyone to answer it. Do we have any indication of how many instances this bill could be very helpful in addressing in those situations at school? Or at a school-sponsored event, or?
So I don't have any statistics specifically to Kansas at this point, but I do have a good study from Arizona who enacted this law quite a few years ago on albuterol, and I do have it highlighted, so let me find it.
For the sake of time, if we could
So-
just get that as a committee, I think.
Sure, do you want me to just send you that
Yeah,
article?
that
It's a
would be
great article that
Thank you.
really shows the
Thank you,
benefits.
Kimberly. And I do have one other quick follow-up, Madam Chair. Previously, I asked the question about training, and I see where Jenna addressed the training. What I'm kind of concerned about is who's providing the training and the certification, because I also notice, and I think this is great, by the way, having been in schools, but I'm concerned about making sure that the individuals administering this are properly trained, and it doesn't look like there's anywhere that says the training must be provided by the school nurse or by a medical personnel and not part of a 5-minute in-service, because it looks like it also releases not just the individual from liability, but the school itself.
So
And so I want to make sure that if we're going to give people, cover for doing this, that we've done everything to make sure they are properly trained. Thank you, Madam Chair.
So we do already, as school nurses, in our School Nurse Practice Act, have the ability to delegate certain medications, and that includes epinephrine and albuterol. So if it's prescribed for a student, we are able to delegate to other school personnel to be able to give those medications. We have each district has their own, but we have like a form that we have to fill out. We have to train the individual on the signs and symptoms, how to give the medication, how to make sure it's the appropriate medication, and then we document that they understood that, and then we watch them deliver the medication to somebody or a simulation of that. And we do that twice in the first semester, and then we follow up and do it again in the second semester so that it's ongoing training. And so that would just translate to the stock medications also.
I don't mean to interrupt. I just know we're quick on time. Yeah, and I think that's great. I want to make sure that it is the school nurse or appropriately medically trained person who is doing that training, and I do not see that in the bill.
Okay,
That's my concern. Thank you, Madam Chair.
Well, go to the revisor for that, because I thought it did say the school nurse would be the one that would be training. Yeah.
Committee, other questions? Senator Steffen.
Thank you, and anybody who testifies is welcome to answer this. Though Leah kind of referred to it. She talked about how most kids already have medications that are known to the school nurse. But then this takes it clear into large gatherings and treating people you don't know anything about their history on, people you don't know. Seems like a bold step.
Thanks, Senator. I acknowledge your concern. This is designed to allow people to administer life-saving care. So if somebody is sitting in a school assembly, maybe they have a peanut allergy and somebody next to them opens up a snack pack or something and they go into anaphylactic shock, maybe they're the grandpa or something, this allows the school personnel to administer that. I understand your concern, but I think the concern is it's better to be able to save a life than not.
Assuming the correct diagnosis is made. Quick follow-up question. Somebody said that this is really kind of already being done. They're delegating authority away from the school nurse to administer medication. So I'm assuming that the schools have liability coverage now. Is that a fair statement?
I'm not an attorney or an insurance expert, but I believe so.
Additional questions, committee? Senator Alley.
Thank you very much, and this is not about schools, but do we have those pins here in the State House? Are those available to us here if we would have someone who would have a peanut allergy in the gallery at the Senate? Would we have a pin here?
yet. Yeah, yep.
Go ahead, Jenna.
Oh, I was going to say the same thing. I know we have AEDs, but I'm not aware of any EpiPens or albuterol. Maybe one of the physicians in the house. I remember Dr. Clifford talked about having an overdose kit that he would keep, but I don't know if it has that in it as well. But it's nothing that the state itself has.
Committee, this closes the hearing on House Bill 2547, and we will open the hearing on 2579 with a brief from Jenna.
Thank you, Madam Chair. House Bill 2579 would authorize the Board of Emergency Medical Services to distribute non-prescription over-the-counter medications. Section 1 amends KSA 656144, and that's the list of authorized activities of emergency medical responders. Distribution of non-prescription over-the-counter medications as approved by the service medical director to the list of authorized activities, except an emergency medical responder shall not distribute any medication containing, and those are the Board of Pharmacy definitions for ephedrine or pseudoephedrine. So they could not distribute Sudafed. The bill would take effect on July 1st. Upon publication of the statute book, it passed the House 120-0, and there were no committee amendments.
Questions for Jenna, committee? Seeing none, thank you. We'll go to our first conferee, which is Con Olson.
Thank you for the opportunity to speak with you today. Con Olson, I'm with the Kansas EMS Association. Our association represents about a little over 100 ambulance services and about 2,300 EMS providers across the state. And our support for this bill would allow us to be able to, at functions like standby events for athletic events or other public events like fairs, to be able to distribute something over the counter as simple as Tylenol if someone were to approach us with a complaint of a headache and those types of things. It also allows us to do a Narcan leave behind option if services opted to. This is totally optional to each service, whether or not they participate. It would have the approval of their medical director and a policy in place that would allow the providers to do that. So it would have physician oversight. It would have quality assurance attached to it through that protocol. And we just wanted to express our support for the bill, and I'd be happy to answer any questions when appropriate.
Thank you, and we will ask questions after the last conferee. And our last conferee is Paul Davis.
Good morning, distinguished members of the committee, Chairwoman Gossage. Thank you for allowing me a moment of your time this morning. My name is Paul Davis. I'm the director of the Department of Emergency Services in Johnson County, and MEDACT, the county's paramedic ambulance service, is one of the divisions in my department. As director of one of the largest ambulance services in Kansas, I stand as an advocate for House Bill 2579 in this version that was passed unanimously on February 22nd. And this bill seeks to clarify the current statute regarding EMS professionals' functions within their scope of practice. Presently, the law does not expressly grant authorization in any circumstance to paramedics, emergency medical technicians, or other emergency EMS professionals to distribute or leave behind over-the-counter medications with those who have a valid need. In the bill that was introduced through the House Committee on Health and Human Services, we seek to include the express authorization that this bill would offer, including the ability to distribute over-the-counter medications as approved by the local medical director. This authorization does not impose requirements on any local jurisdiction, medical director, or ambulance service. Rather, it simply allows us to collaborate locally to determine what is necessary for our communities to meet the needs of our residents, to make informed decisions and function within our respective scopes of practice. Some may suggest that we seek expanded regulation from state government. That is not the case with this bill. We absolutely do not need additional rules that create more restrictions or onerous costs for local ambulance services and EMS agencies. We merely seek clarity where none has been provided and where the current law is silent, creating confusion and risk. Therefore, I respectfully ask this esteemed committee to support the bill as passed by the House and pass on to the full Senate for their vote. Thank you for your time.
Committee, do we have questions for the proponents? Yes, Senator Petty.
Sorry for this question to go to you, Paul, and thanks for being here. So, so this bill helps clarify what you, as you just expounded on, what you are able to do. And was that because the EMS board has not been clear about what EMS could do?
We did ask for some clarity, and we don't believe that we actually got what we were looking for at the time that the bill was offered.
And have they, since this time of the bill being offered, has that changed?
There have been some discussions and some guidance documents offered.
And so this would just clarify that that EMS can do the things that are mentioned in this bill.
Yes, ma'am.
Thank you.
I have a follow-up question to that as well, and that is, in the supplemental note, it mentions there was opponent testimony by the board, and I don't see any of that opponent testimony here. I see neutral testimony. Could you clarify that?
There was opponent testimony in the House committee, and that has since changed, and I know that the executive director is here, and he may be able to speak better on that matter.
That would be Joseph, is that correct?
Yes.
And is he available? Hi, would you come and address that, please?
Good morning, Madam Chair. Joe House. I'm the Executive Director of the Emergency Medical Services Board. And yes, we were opponents when this was over on the House side. We have since switched to a neutral testimony on this, as it's very clear from the industry and from within the providers that they want the clarification. And so if they believe it's necessary, it's necessary. The board does still stand that it's unnecessary language, but if they need it for clarification, so be it.
Thank you very much. Committee, other questions? Seeing none, this closes the hearing on House Bill 2579, and committee, we are adjourned.